Another regulatory mechanism that we don't want to forget about is thirst. This also can increase our plasma osmolality. Decrease our plasma osmolality. And when there's more sodium and less water in the body, it makes a person thirsty. And that's controlled by the hypothalamus that triggers us to drink additional fluids to try to increase our volume or else decrease the osmolality if we have too concentrated of a solution. Some interesting things to keep in mind when we're thinking about I&O is that in a 24-hour period of time, the typical adult will lose between 1 and 2 liters a day, or there is some difference between sizes of people. So 1 milliliter per kilogram of body weight per hour is the average. So you could take somebody's weight divided by 2.2, and that's how many milliliters per hour they should probably be putting out. If they've been taking diuretics or if something's stimulating their antidiuretic hormone, this might change, but that's a pretty good estimate. Losses of fluid occur through the skin, also by sweating, so we wouldn't see that when we're measuring output. Water loss occurs through the lungs by evaporation, and that accounts for about 300 to 400 milliliters a day. And then in the gastrointestinal tract, here we're talking about mostly feces, that's 100 to 200 milliliters per day. But in a 24-hour period, the output and the intake should be approximately equal. But you can see here that we have a little bit, say, 400 to 500 milliliters of wiggle room that we can lose through other methods. So that's where we come up with our recommendations to drink 2 to 3 liters of water per day. That's 2,000 to 3,000 milliliters, which is pretty close to what we expect to have in output. On our nursing assessment, there's quite a few conditions that might put someone in an electrolyte imbalance or cause the I&O to not match up. Vomiting, diarrhea are going to cause increased water loss. Kidney diseases might cause water retention a lot of times. Diabetes frequently results in increased water loss. That's one of those cardinal signs of diabetes is high urinary output. Salicylate poisoning, again, salicylates are aspirin. Burns, we lose a lot of water through burns, and it's very difficult to keep someone hydrated, as we'll talk about when we get to that chapter in the skin chapter. CHF, congestive heart failure, causes water retention. Things like ulcerative colitis or having a colostomy would lead to higher output of water because they're going to lose more in this feces than what they normally would. And of course, taking diuretics such as Lasix can certainly increase the output, as those of us that have worked in healthcare have seen. Some of the signs and symptoms associated with fluid and electrolyte imbalances would be fatigue, palpitations, that's like a racing or irregular heart rate, dizziness, edema, of course, which we'd see more with the kidney disease or the congestive heart failure, muscle weakness or cramps, shortness of breath, confusion. Vital signs a lot of times can give us a pretty good indication of what's going on fluid and electrolyte-wise. Pulse and respiration, temperature, blood pressure, all can indicate changes in the fluid and electrolyte balance. Temperature variations can be associated with either fluid volume excess or deficit, so that one's a little bit tricky. Your pulse rate often will speed up in response to dehydration or hypovolemia, as we call it, low blood volume. Blood pressure will do kind of the opposite. It's going to drop when we have hypovolemia and go up when we have fluid retention. Respirations are probably the most minimally affected by the electrolyte changes, but they can happen as well, especially when we get into magnesium imbalance. Too much magnesium can really knock out respiratory rate sometimes. When we have a patient with a fluid and electrolyte disorder, accurate records of their intake and output are essential, and so that whole thing of on output putting ×3, meaning they urinated 3 times during the shift, that's not going to cut it, because that doesn't tell us anything. You can urinate 100 milliliters or 1,000 milliliters at one time, and we need to be more specific than that. Sometimes a doctor will specifically order accurate INO, and I think that's kind of a funny order, but it makes sense because so often we're putting things like ×2, ×3 on our output, and that's just no good. It needs to be in milliliters so we can compare the intake to the output. If we can't get that, meaning maybe our patient is incontinent, I guess theoretically you could do like they do with the infants and weigh the diaper and do all that mathematical, but I've never seen that done in adult health before. Usually what we do, if the doctor really needs super accurate output and we can't get it because the person's incontinent, we call and we say, hey, look, this person's incontinent. Do you want us to put a Foley catheter in them? Because that's what's going to have to be done in order for us to get accurate output. And then the doctor will weigh the risks of if it's worth it, if it's that important to put a Foley catheter in, or cancel the order. A change in urine output may reflect attempts by the kidneys to maintain or restore balance, or it may reflect a problem that caused the fluid disturbance in the first place. We can also look at our urine characteristics for clues as to what's going on, and so that's why on most output sheets it has you also describe the urine. Is it really dark? Is it pale? Does it have an odor? Is it real concentrated? That type of thing, because that can help us make the determination. A person's skin can also give us some indicators as to what's going on fluid-wise. Is it moist? Is it dry? How about the turgor? And again, turgor probably isn't the best measure of hydration status in an elderly person because they just have natural loss of skin elasticity. If you are going to measure the turgor and you have to do it in an older person, you need to go for the forehead or the sternum of the chest, or maybe even on the inner thigh, or 3 of the places that give you a little bit more accurate. Avoid the hand or the back of the hand or the arm, because especially in the elderly, that's naturally going to have that loss of elasticity and it might give you a false reading. In dehydration, skin may be flushed. With excessive fluid volume, we're going to see the puffiness or edema. Edematous is what we call that type of tissue. It may be pale, cool, clammy. Severely dehydrated patient has a pinched or drawn facial expression. The eyes are sunken in, but if they have puffy eyelids and fuller cheeks, that suggests overhydration or retention of water. Oh, here's a slide showing the sternum, inner aspect of the thighs and the forehead. And edema, if it's pitting, that means we can push in on it and it leaves a little bit of a depression, and then we can grade that on a 1 to 4 scale. On your clinical assessment sheet, we have you talk about the patient's mucous membranes, and that's another indicator of fluid status. The tongue turgor, we're looking at their tongue and seeing if it has these really deep furrows. Everyone's tongue has one, but if you see really long furrows in the tongue, that's a sign of dehydration. Moisture of the oral cavity, a dry mouth may be the result of deficient fluid volume or mouth breathing, but I don't put a lot of weight on that because a lot of times different drugs can cause dry mouth as well. Veins, we look at the veins and we, with pulses, we test the strength of the pulses, but one of the things that on your assessment sheet about veins is it asks you if they have JVD or jugular vein distension. And I've had students ask me, what does that mean before? And so I found this picture that's showing you the jugular vein is that vein in the side of the neck that goes under the ear. And most people, you can see their vein. And when they're lying down, you can kind of see it pulsing sometimes. And then as you sit the person up, it gets to where when they're up at a 90-degree angle, you can't hardly see it at all. And so when we're talking about jugular vein distension, it's talking about, does it look like this when they're sitting up, is what you're looking for. And You can Google some pictures on YouTube, and it's pretty obvious. I mean, that thing is huge and pulsing. And like I said, when someone's sitting straight up, you should barely be able to see it just above the sternum, which is right here. But don't assess it when they're lying down because it's normal to be able to see it there. Some of the lab values that we use to determine fluid and electrolyte status are urine pH. And when we get into acid-base imbalances here in the next lecture, we are going to cover pH really well. Urine-specific gravity is a measure of the urine concentration. This is a pretty good indicator of fluid balance. Osmolality, we already talked about earlier. That's how concentrated something is. And so you can have how concentrated is the blood, how concentrated is the urine. So blood would be serum osmolality, the urine would be the urine osmolality. It's just talking about how concentrated they are. Urine creatinine clearance test is a little bit different than just the plain old serum creatinine that we see on a lot of our labs. Serum creatinine is done a lot more often, but the urine creatinine clearance test probably can give more information. It takes a lot more work to collect. It's a 24-hour urine specimen, and when you collect that, you have to toss the first specimen, and then you start timing it, and then you collect all the urine. You have to keep it cold, and so it's a lot of work to get this, so that's why they're not ordered quite as often. But it can really do a good job of telling us if we have any kidney damage going on. Urine sodium, urine potassium, all are going to measure electrolytes that are in the urine, and a lot of times we can tell what's going on in the blood by what's coming out in the urine. Now, blood studies, serum hematocrit, hemoglobin and hematocrit are really common tests that we do and that we see the results of. The hematocrit a lot of times will be elevated when someone's dehydrated. So that means the concentration of the blood goes up because the water is going down. Here's the serum creatinine. Again, that's different than the urine creatinine. Urine creatinine clearance is a 24-hour urine specimen, but this is just a blood draw, and it's real easy to do, immediately available, and so this is a real common test. Creatinine and blood urea nitrogen, or BUN, are a type of metabolic waste product, and so usually when someone's in some type of kidney problem or kidney failure, you're going to see elevated BUN and creatinine. The creatinine is a little bit more specific to that because or to kidney problems, because the BUN can be thrown off by, let me see on my next, yeah. BUN is associated with hydration status, so it doesn't necessarily, a high BUN doesn't mean that someone's in kidney failure, but a high creatinine is a little bit more specific and isn't thrown off by the dehydration as much as the BUN is. And then here I talk about the hematocrit. Basically what I said, the blood's more concentrated, so the hematocrit goes up. Albumin, a lot of times we use albumin to determine nutritional status, but it can also has a lot to do with hydration. And serum electrolytes like sodium, potassium, chloride, and calcium. We'll be talking more about those, but we'll take them one at a time.